السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
عليكم السلام.
How are you guys?
الحمد لله.
Alhamdulillah, walaikum salam.
Okay, today we will practice some stations for ALS part 2. We have for practice Obaid, Kalian, Anwar, Basamat, Amar. Okay. So today, inshallah, we will practice opiate, lidocaine toxicity, hypothermia, rapid sequence induction, intubation, and cardiac arrest. Just to remind you, general approach, introduction. Before the mannequin, hand over from ambulance crew and ambulance. Then mannequin ABCDE, then hand over to relevant specialty, then reassess again ABCDE. Regarding the ABCDE, full assessment, full findings, including diagnosis, full call, full intervention. Regarding the assessment, full assessment, it means in airway, you will ask, is the patient conscious? Is the airway patent? If yes, or the examiner is silent, you will verbalize apply high flow oxygen. If the examiner said no or not patent, you should verbalize clear airway, oropharyngeal, nasopharyngeal, and apply high flow oxygen. Regarding breathing, expose the chest, connect to all monitors, SpO2, RR, trachea, neck veins, inspection, palpation, percussion, auscultation. Regarding circulation, you will ask about 4 points: blood pressure, CRT, peripheral pulses, heart rate. Regarding disability, ask about 4 points: GSS, any signs of lateralization, pupils equireactive, blood sugar. Then exposure, expose whole body, any other abnormalities, and temperature. Regarding massive transfusion protocol, the first action, 4 units back the RBCs. If not available, give O blood group. If gender female, give negative. If gender male, give positive. If postmenopausal, give positive O 2 units. In the second circulation, in second assessment, if the blood pressure is still low, ask about blood results, then correct abnormalities. In the next circulation, ask about blood pressure. If still low, ask about blood results and correct abnormalities. Okay, we start first station. Obaid,
Yes, sir. Thank
how are you?
Good, sir. Alhamdulillah.
Okay, you have 30 seconds and 6 minutes. So the patient collapsed in street, so you should think about opiate. Maybe they will say patient used medicine like methadone or anything like that. So even you did not check the scenario or you are not concentrating, you did not see the word straight. So no problem. You can catch the diagnosis from the trial. You will catch the diagnosis and disability. You will give the first dose of naloxone 400 microgram in disability. When you reassess disability in the second disability, after 2 minutes, you should give naloxone again 400 microgram. Someone will say 800 microgram, no problem. The second dose 400 or 800 microgram, it's not a big issue. Someone will say after 1 minute, I will assess, no problem. You want after 1 minute, after 2 minutes, after 3 minutes, it's not a big issue. So the most common is 2 minutes and 400 microgram. If the patient has no response at all, I mean same parameters, you should give bolus. If the patient has any change of any of the triads, any change in RR, CNS, I mean GSS, any change in the pupil, for example, before it was pinpoint, now constricted but not pinpoint, it means it changed. So you should start infusion. Clear, Obed?
Yes, sir.
So infusion, it will be 60% of the previous doses, not doses. Okay?
Okay.
Means 60% of the rescue dose. Okay, you have 30 seconds and 6 minutes.
Hello, good morning. I'm Dr. Obed, ED Registrar. So today we will be receiving, may I know your grade and name and grade, please? Yeah, your ACLS provide. Okay, you will take care of the airway. Another staff will take care of the IV access.
Patient
So we are
arrived.
receiving, yes, any handover from the ambulance crew?
We found this patient collapse in the street and he has dirty clothes and marks in his arm.
Okay, you found this with the dirty clothes and marks in the phone. Do you do any intervention for him?
We give him oxygen.
Okay, please. Is the patient conscious?
The patient is unconscious.
Okay, look, feel, and see for the life.
The
Pulse is
patient
there.
has signs of life.
Signs of their patent. Okay, so airway is patent.
Airway is
O-
patent.
Okay, apply high flow oxygen. Insert a OPA. Okay, so we'll check for the expose the chest. We'll check for the saturation.
Saturation 9.4.
Okay, respiratory rate.
4.
Okay, trachea,
Central.
neck veins,
Normal.
inspection.
Respiratory, or I mean no respiratory effort. Chest rise is decreased.
Okay, palpations,
Decreased expansion.
percussion, os-
Normal. Resonance.
oscillation of lung and heart.
Normal.
So in the breathing, we found the respiratory rate is low. So we will start him with a bag mask ventilation. Every 6 seconds, we'll give one breath. Okay, and so we'll go with the circulation now. Blood pressure.
Blood pressure is not recordable.
Okay, can we look for the signs of life? Is there?
Yes.
Okay, CRT.
Not recordable.
Okay, peripheral pulses.
Weak.
Can we see the heart rate in the ECG rhythm? Okay, so we have a sinus rhythm, ECG. Okay, so we will insert IV access, send for all biochemistry toxicology, two IV access, and we'll start with the IV fluid bolus, 250 ml start. Okay, can we go with the deformity, GCS?
GSS is 9.
9. Okay, any signs of local lateralization?
No.
Pupils?
Pinpoint.
Okay, and blood sugars?
Blood sugar 5 millimole.
So with the above, we have a triad of like unconscious patient with respiratory distress, like bradyapnea, and we have pinpoint pupils. We can suspect like opioid toxicity. We will prepare for naloxone, 400 micrograms IV stat. Okay, then we'll expose the body. We'll watch for any other abnormalities. Okay, temperature. Okay, fine. So we have a patient with this query opioid toxicity. We will again go back to the brief history. We'll call for the ICU team. Inform the ICU team that we have a naloxone toxicity with reduced unconscious patient with reduced GCS and respiratory bradyapnea. So we'll go back to the airway. Airway is patent, yes. Um, and now saturations.
Saturation is decreased now, is 50.
Okay, we will plan for early intubation. Respiratory rate.
Respiratory rate is still 4.
Okay, we'll put an OPA and NPA and start the proper AMBU, position him and plan for early intubation. Call for the anesthesia for early intubation. Then we'll go back to the circulation, blood pressure
Low.
low. Can we check for the signs for signs of life? Look, feel, and listen.
We said low, not recordable. We did not say no, not recordable. We said low, low.
Low. Okay. So we'll give like 1 minute passed. We'll give another naloxone, 400 micrograms, IV stat. Okay, we'll again go with this checking of the GCS and improvement in the GCS now.
Same,
Same. Pupils.
same.
Okay, so we'll go back to the circulation now to see how is he doing. Like now the breathing saturation.
Same.
Same. So did we
Patient is
intubate the
not
patient?
responding now.
Okay, so check the pulse.
No signs of
Check
life.
for. Okay, stats high quality CPR. Attach defibrillator pads. Call for the ALS resuscitation team. Okay, CPR is ongoing. We have an ECG rhythm. Okay, on the system we have a pulses electrical activity. We give an injection adrenaline, 1 mg stat. So 30 is to 2. High quality CPR. 30 compressions followed by 2 breaths.
Thank you.
Okay. Thank you, sir.
Okay, thank you, Obed. This patient already has collapse in the street, dirty clothes, and maybe homeless. Okay, maybe needles in his arm. Maybe they will say they found needles or syringes beside him, right? Okay.
Yes.
So the airway is patent. Already you finished the introduction, handover from ambulance crew, done. And then ABCDE, okay. Airway, the patient unconscious and the airway patent. Then regarding breathing, you found bradypnea and poor respiratory efforts. I mean, chest rise is very poor, expansion very poor, otherwise normal. So you started back valve mask, one ventilation every 6 seconds. Excellent. In circulation, you found low blood pressure. Did you give fluid in the first circulation?
Yes, sir. 250 ml bolus.
Why 250?
Have 500 liter.
500. Any
500.
contraindication here?
No, sir. Lungs were
Did
clear.
I mention bilateral basal crepitation?
No, no, sir.
Even bilateral basal crepitation, if chest infection, not contraindication. If the bilateral basal crepitation associated with abnormal heart sounds, associated with congested neck veins. Clear?
Yes, sir.
So no contraindication here. Any trauma? No. Any bleeding? No. So give 500 cc. In the second circulation, you did not give again fluids. I told you in the second circulation, blood pressure is low and you ignored, right?
Agreed.
Yes. So at any time you find no contraindication for fluid, give 500 cc. In the second assessment, still low and still no contraindication. I said still no contraindication because maybe after the first bolus, you find the contraindication. Did you get my point?
Yes, sir.
Maybe he has congested neck veins after the fluid. Maybe he has something wrong after the fluid. So don't give. So before any fluid, check any contraindication. check the neck veins. If the neck veins are congested, take care. Any patient, whatever he is cardiogenic or he has liver problem or anything like that. So check his neck veins. Anyway, you are doing well. So once the patient has no signs of life, then verbalize the patient cardiac arrest, activate cardiac arrest call, adult cardiac arrest call, start high quality CPR 30 to 2. The patient has PEA, non-shockable rhythm, give adrenaline 1 milligram IV, okay, or IO, no problem. Then you will consider for H40s. What is the most likely problem?
Toxins.
Toxin. Okay, it could be opiate toxicity. So, did you give the first dose in the first assessment and first disability?
Yes, sir.
400
Alex.
microgram. Did you verbalize 2 minutes passed? I will assess the patient.
No, sir.
So, in atropine, in circulation, in bradyarrhythmia, I'm talking about different station. Once you plan to give another dose of atropine, you should verbalize 5 minutes past. In anaphylaxis, different station, you are giving adrenaline in anaphylaxis every
5 minutes.
5 minutes. So after you finish exposure, you can verbalize, I need to hand over this patient to blah, blah, blah. I will reassess the patient 5 minutes past, like that. Clear?
Okay.
So every reassessment, verbalize the timing, okay? Not the real timing, the timing interval between doses, clear? So you are giving naloxone every 2 minutes. Then once you finish exposure, you can verbalize, I need to hand over this patient to ICU team. And then verbalize 2 minutes past. What about airway? What about breathing? What about circulation? What about disability? So you can say no response. The triad is still same. Triad of opiate toxicity is still the same parameters. Then you can give again bolus of 400 microgram. Okay. Well done. So you are doing well. I will give you 8 out of 10. Thank you. Kalyan?
Burhani,
Yes,
Hello,
please.
sir.
last session you stopped the turn on me and you said you will start from you next
If you
session.
did, if you did not attend today, we will wait for you.
No, I attend already. You will
You
start.
attend, but you attend late.
Sir, it's okay, sir. He can do this station. I will do the next one.
If you did not attend, we will call you or we will go to your home.
Just I open the laptop and I attend. Just I open the laptop. Wallah.
Okay. If you want
When I
your
see the
turn,
notification in the phone.
Kalyan said if you want to do, you can do.
Okay, no problem.
Okay.
Who will do, Omar or Kalyan?
Omar?
Okay.
Okay.
So this station, the patient was in dressing room and junior doctor, he was doing sutures. After that, he found the patient collapsed. So we explained this station last session, and this patient collapse here may be something wrong in brain or in heart. Any toxin like that, brain, heart. So the medication only intralipid. Okay. So oxygen, fluids, intralipid. If the patient is alive, even he's unconscious, you can give oxygen, oropharyngeal, nasopharyngeal. Then, if bradypneic, you will give back valve mask. If the patient is hypotensive or even not hypotensive, fluids, then intralipids, 1.5 ml per kilogram. Kilo Omar?
Yes.
Okay. So, if the patient is unconscious, look, listen, and feel maybe cardiac arrest. So, if cardiac arrest, the first cycle take your time to do everything. Clear, Mama?
Yes.
Okay, you have 30 seconds and 6 seconds. Also, in cardiac arrest, it will be same dose, bolus. Infusion after response. So if the patient became responding, how you know? It change in GCS, it change in if he was in cardiac arrest, now he's at risk. So you should continue infusion. Clear, Omar?
Yes.
Okay. If you are happy to start, you can start.
Okay, good morning. I am Dr. Omar, the registrar. May I know your name and level, please? Okay, are you happy to manage the airway? Okay, I need another nurse to manage the circulation. We are waiting for patient.
Doctor,
Can you
I'm
bring...
the junior doctor here. I was doing sutures and I found the patient collapse. Please help me.
Okay, don't worry. We can. I will assist the patient and manage him. Please come. Okay. What about airway? Is the patient conscious?
The patient is unconscious.
What about look, listen, and feel any sign of life?
No signs of life.
Okay, please activate cardiac arrest team, connect all the monitor, start high quality CPR, ventilation, compression to ventilation ratio 30 to 2, insert to IV line, extract blood for hematology, biochemistry, blood culture, blood screen, infection screen, and this patient most probably have cardiac arrest. Can we check the heart rate? Okay, this patient have shockable risk. Please give the patient an unsynchronized DC shock 200 joule biphasic, 100 joule biphasic shock given. Okay, continue CPR for 2 minutes. Continue CPR for 2 minutes, and I will think about for H and for T. Most probably is T toxin, lidocaine toxicity, and we will give intralipid 1.5 ml per kg bolus. Okay, given. Can we check pulse, please? Okay, still PTAC, prepare another shock. Please give 200 joule unsynchronized DC shock. 200 joule DC shock. Continue CPR for 2 minutes. Okay, 2 minute pass. Can we check the risk? Check pulse. Any sign of life?
The patient has signs of life.
Okay, patient has sign of life. Okay, we reassess the patient. Is the patient conscious?
The patient is unconscious.
What about airway? Patent or not patent?
The airway is patent.
Airway is patent. Please put the patient on high flow oxygen. I will assess respiration. What about saturation?
9.4.
Okay, what about respiratory rate?
40.
Trachea?
Central.
Neck veins?
Normal.
Chest inspection?
Normal.
Chest palpation?
Normal.
Percussion?
Normal.
Auscultation of lung and heart?
Normal.
Okay, what about blood pressure?
Blood pressure is normal.
Okay, CRT?
Normal.
Peripheral pulse?
Normal.
Heart rate, I will check the rhythm in the monitor. Heart rate is showing ventricular tachycardia. So the patient have ventricular tachycardia unstable. Please give the patient an synchronized DC shock 120 joule. 120 joule synchronized DC shock. Okay. Also, we will give the patient intralipid 1.5 ml per kg infusion. Okay. I will now check, go to D, disability, GCS.
Just as the patient is unconscious.
Any sign of life, look,
Yes.
listen, and feel.
Yes.
There is sign of life. What about the pupils?
Normal.
Sinus lateralization.
Normal.
Glucose, random.
Normal.
Okay. What about temperature?
Normal.
Okay. I will expose the patient any other abnormality. Okay, I will assess the patient now. Airway. Is the patient is the airway still patent?
Beta.
Okay. What about saturation?
Normal.
Okay. What about blood pressure?
Normal.
Heart rate. Still the patient have still have unstable VTAC. I will give the patient another DC shock 140 joule synchronized DC shock. Okay, shock given. I will assess the patient. What about is the patient still unconscious? Is the patient conscious?
Unconscious.
Airway still patent.
Beta.
Okay, blood pressure still saturation is still 94 or decreased.
Normal.
Okay, and still heart rate is patient showing unstable unstable V tach. I will give a third shock, 150 joule synchronized DC shock. Please shock given. Okay. What about heart rate now? Still a patient unconscious.
Unconscious.
Okay, I will give another bolus. I give 1.5 ml intralipid bolus IV. I will assess the patient. Since the patient is the patient now achieving the heart rate, the normal sinus rhythm. I will assess the patient. Is the patient is conscious?
Yes, conscious.
Okay, what about airway?
Beta.
Okay, and heart rate? Saturation?
Okay, thank you. Your time done.
Okay.
Okay, excellent, Omar. Did you give fluids to the patient?
No, I forget.
Okay. So you should give oxygen, fluids, even normal blood pressure, and then intralipid. Intralipid bolus. You can repeat bolus. You can repeat bolus. If the patient has response, you can start infusion. Clear?
Yes, we can consider patient come from a risk is a response.
If the patient has ROSC, if the patient has
Yes,
ROSC, you can start infusion, and you did that.
yes.
Okay.
It's
Wait. So the new guidelines regarding this shock, they said they said the signs of instability, shock, syncope, myocardial ischemia, signs of heart failure, and the patient has ROSC. Clear?
yes,
So if the patient has VT after ROSC, even he's conscious, it's considered unstable. Clear?
okay,
Even he's conscious, yes. But as usual, we should ask about assessment. Okay? We should ask about assessment. So assessment here, we are talking about what? About uh, is the patient conscious? Is the airway patent? So in every airway, you should ask about conscious or not, the airway patent or not. Clear?
yes,
You did that, but not every time. Okay. So
yes,
why I'm asking about conscious or not? Because in general, if he's alive and he has arrhythmia, I want to see he's stable or unstable. Easy?
yes,
I mean, no need to go to D to check stable or unstable. Okay. So if airway, the patient is conscious or unconscious, good. In breathing, I will understand hypoxic or not. In circulation, I will understand hypotensive or not. Okay. So if I find any of the five signs of instability, shock, syncope, myocardial ischemia, or ROSC, it means unstable. Clear?
yes.
Okay, well done. So I will give you 10 out of 10. Thank you.
Thank you.
Well done. Okay, so oxygen, fluids, and intralipids. Next one, Kalian.
Hello, sir.
Yes, how are you?
Good, sir. Thank you.
Okay, so this patient, he fell in bathroom, so you are expecting hypothermia. They mentioned clearly in the scenario temperature is 26, right?
Yes, sir.
So it's obvious. So you have one of the causes of unconsciousness or one of the causes of cardiac arrest. Unconscious, it means still alive. Clear?
Okay.
So
Okay,
why
sir.
this patient is unconscious? Because of hypothermia. Why this patient is hypotensive? Because of hypothermia. Why this patient is blah blah blah? Because of hypothermia. Maybe cardiac arrest? Yes. Because of what? Because of hypothermia. Okay. So
Okay, sir.
regarding IV drug user, maybe cause? Yes. So if they mention both in the scenario, so if the patient in cardiac arrest in the first cycle, you will verbalize everything in the first cycle. Easy?
Okay,
So
sir.
in the first cycle, you have 2 minutes. Don't ask about 2 minutes until you verbalize everything. And you should consider for H40s, the most likely problem is hypothermia and toxins. Why? Because mentioned already in the scenario, right?
Yes, sir.
If
IV
you,
drug user.
if you did not find IV drug user, don't mention toxin. Easy?
Okay, sir. Okay, sir.
Okay. So you can say the most likely problem is blah 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 blah. Okay. Then ask the nurse, check temperature by low reading thermometer. So you will do what? Connect a monitor, check, you give insert the two IV access, extract the blood for blah 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 blah. Give the patient warm IV fluids. So you will start passive and active rewarming. Mention passive, like for example, dry the patient, keep the patient dry, and warm the patient by blankets, turn on the air condition warm, and give the patient warm humidified oxygen, give the patient warm IV fluids. Clear?
Okay, sir.
Okay. So if you find BAA, you can say the rhythm is showing non-shockable BAA. Withhold cardiac drugs. Easy. Cardiac drugs, it
Okay.
means the adrenaline and amiodarone. Okay. Or any
Okay.
drugs. Any drugs. Okay. Because any drugs in resuscitation consider cardiac drugs. Clear?
Okay, sir.
Okay. So once you finish everything, so you will ask 2 minutes passed, check the rhythm and signs of life. The nurse or the examiner will say no signs of life. Then you can verbalize, so the patient is still in non-shockable rhythm, BAA. Resume high quality 2 minutes CPR and resume passive and active rewarming. Nothing else. Okay?
Okay, sir.
And check temperature. So 3 points every cycle. Resume high quality CPR 2 minutes. Resume passive active rewarming. What is the temperature now? Easy.
Okay, sir.
If you find temperature increased more than 30, you can give cardiac drugs. Okay? Okay,
Okay, sir.
so ask 2 minutes passed, then the patient in shockable rhythm VF. What you will do? So you will give the patient this shock. Okay?
Okay.
How much? 200 joules biphasic, unsynchronized. Then resume same. After the shock, resume high quality CPR 2 minutes, resume passive active rewarming, and check temperature. So the 3 points you will verbalize every time. Clear?
Okay, sir.
The temperature less than 30, you will give shock? Yes, no problem. But after the third shock, if you want to give any further shock, you should check the temperature. If less than 30, withhold further these shocks and withhold the cardiac drugs. Clear?
Okay, sir.
What if the temperature more than 30? You can give any shock. You can give cardiac drugs, but double interval. What does it mean, double interval? Adrenaline, you are giving every how long?
4 minutes.
4 minutes.
Here, 8 minutes.
It will be every 8 minutes. Excellent. So usually, or in all patients in cardiac arrest, you are giving adrenaline every 4 minutes, but in hypothermia, more than 30, you will give every 8 minutes. Okay. And what about amiodarone? You are giving after the third shock, then the fifth shock, right? No,
Yes, sir.
it will be after the third and then after the seventh. Clear?
Okay, sir. Even if temperature is less than 30 after third shock.
No, if temperature less
Uh,
than 30, don't give cardiac drug.
withhold.
Withhold.
Okay.
I'm talking about the temperature 30 to 35.
About that.
If
Okay.
the temperature 30 to 35, you will double interval for adrenaline and amiodarone. Okay? It
Okay.
means amiodarone after third shock and then after seventh shock, not after fifth. Clear?
Okay.
Okay. It means amiodarone, it will be instead of um, every 4 minutes, it will be every 8 minutes also. Clear?
Okay, sir.
Okay. So you have 30 seconds and 6 minutes.
Can I start, sir?
Yes, please.
Hello, I'm Dr. Kalyan, ED Registrar. I'll be your team leader today. May I know your names and grades, please? Are you ALS trained? Can you please prepare airway equipment? Can you please prepare circulation equipment? We are about to receive a patient who was found unconscious in the bathroom with low temperature.
Patient arrived.
Patient. Any handover from the ambulance crew?
The patient was collapsed in the bathroom. He has temperature very low, and we found history IV drug user.
Okay, thank you. Is the patient conscious?
The patient is unconscious.
Look, listen, and feel any signs of life?
No signs of life.
Guys, this patient is in cardiac arrest. Please call adult cardiac arrest team. Start high quality CPR. 30:2. 30 compression is to two ventilations with a bag wall mask. And expose chest, connect all monitors and assess the rhythm. Insert two IV lines and extract blood for hematology, biochemistry, blood gases, blood culture, and toxicology screening. And I will consider 4 H's and 4 T's. Can I assess the rhythm, please? Can I see the rhythm? Or the rhythm? This pulse patient is in pulseless electrical activity. It is a non-shockable rhythm. Please give adrenaline. Can you please check the temperature, please,
26.
with the low reading thermometer? 26. So withhold cardiac drugs and please continue CPR and start active rewarming and passive rewarming. Active rewarming means give warm humidified oxygen, give warm IV fluids, and passive rewarming means remove all wet clothes, dry the patient, cover the patient with warm blanket, and turn on AC to in here room heating. Then continue CPR for 2 minutes. High quality CPR. 2 minutes passed. What's the rhythm now? Any signs of life?
No.
What's the temperature?
Same, 26.
Resume high quality CPR for another 2 minutes. Continue active and passive rewarming with all cardiac drugs. And what's the 2 minutes passed? What's the rhythm now? Any signs of life?
No signs of life.
Patient is in VF. This is a shockable rhythm. So please give unsynchronized DC shock 200 joules biphasic. Shock given. Continue CPR, high quality CPR for 2 minutes. Continue active and passive rewarming. 2 minutes passed. Any signs of patient is still in VF? Please give second DC shock 200 joules unsynchronized biphasic. Continue high quality CPR and continue active and passive rewarming. 2 minutes passed. Patient is still in VF. Give third shock 200 joules unsynchronized DC shock. Withhold cardiac drugs. Continue CPR. So patient is still in VF. So we already given 3 shocks. And withhold shocks and cardiac drugs. Continue active and passive rewarming. Continues high quality CPR for 2 minutes. 2 minutes passed. Patient is still in VF. Can you check the temperature?
Temperature is 27.
Patient temperature is still low. Continue high quality CPR for 2 minutes and continue active and passive rewarming. 2 minutes passed. Patient is still in VF. What's the temperature now?
31.
Okay, patient temperature is above 30 degrees. Now we can give shock. Patient is still in VF. Please deliver 200 joules unsynchronized DC shock biphasic. Shock delivered and continue high quality CPR for 2 minutes and resume active and passive rewarming. Okay, patient. What's any signs of life?
Yes.
What's the temperature?
32.
32. Okay, I will reassess the patient now. Is the patient conscious?
The patient is conscious.
Is the airway patent?
Patent.
Apply high flow oxygen. What the oxygen saturation?
Normal.
Respiratory rate?
Normal.
Neck veins?
Normal.
Trachea?
Normal.
Any abnormality in chest inspection?
Normal.
Palpation?
Normal.
Percussion?
Normal.
Auscultation of lungs and heart?
Normal.
What's the blood pressure?
Okay, thank you. Your time done 30 seconds ago. Okay, you are doing it well, Kalyan, but you are sleeping. Okay, so I want you to be fast. Who will
Okay.
ask about 2 minutes, you or the examiner? You. You, candidate, you. Okay, so
Okay.
you can say 2 minutes past. Don't ask him 2 minutes past. It's not question. Clear?
Okay, sir.
You can decide if 2 minutes passed or not. You. No need to wait for the examiner. But regarding the signs of life, you cannot decide, right? You cannot assume.
sir.
So you can say like that. For example, the patient has VF. You can say 2 minutes passed. The patient is still in VF. No need to ask the examiner about signs of life. If you want to ask, no problem to confirm. Clear? Even
Okay, sir.
VF, you can confirm, yes. But what if you did not confirm? No problem. I wish it's clear. So you can say 2 minutes passed, the patient is still in VF. No need to say, what about heart rate? Already you have the heart rate. No need to ask the examiner. Clear, Kalyan?
Okay, sir.
You are wasting time
Okay.
and you are waiting for response of the examiner. This is mistake. So you are wasting here 20 seconds. You are wasting here 10 seconds. You are wasting here 10 seconds. You will find the time finished already, right?
Yes, sir.
Okay, so here in BA, you can say the rhythm is showing non-shockable rhythm BA. Then give the patient blah 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 blah. Once you verbalize everything, you can say 2 minutes passed. Not question. No, you are answering yourself. You should say 2 minutes passed. The rhythm is sinus rhythm. Any signs of life? So the only question is any signs of life. Easy.
Okay, sir.
He will say yes or no. If he is silent, if he is silent, okay, you should understand. You should understand it will be no, because if he want to say anything, he will say. So most likely in this station, they will give you at least 3 or 4 or 5 rhythms. I mean cycles in hypothermia. It's a common station, and they are doing like that. They can give you a live patient, yes. So what if the patient is alive? More than enough, passive and active rewarming. Easy?
Okay, sir.
Okay. So you are doing well, but you are wasting time and you are slow. So in resuscitation, you should show the examiner leadership, resuscitation skills and the leadership skills. Means you are fast, you are active. Okay?
Okay, sir.
I will give you 8 out of 10. Thank you. Next
Thank
one,
you.
Basamat.
Sir, I have a
Dr.
question, sir.
Hani?
Yes, please.
Sir, in this scenario, like post ROSC, like ABCD assessment, we have to recall all ABCD in detail, like a brief, like
In detail.
patient
Full.
in detail.
Full.
Yeah, okay. Okay, got it, sir.
Because
Dr. Hani?
because you received the patient in cardiac arrest, you did not assess the patient at all.
Yes,
Okay?
sir. Hmm. Got it, sir.
Ideally, in real practice, you should do full assessment before and after.
Got it, sir.
But for the purpose of the exam to save time, if you did full assessment before the arrest, do brief assessment after the arrest, after ROSC. Yes,
Yeah.
Bilal.
Sir, one question,
Uh,
please.
th-
Yes, Omar.
this patient who after after he becomes 32 only reach to D, as he is intravenous drug abuser, we can give him naloxone if we find the triad.
Yes, of course, if you find the triad, but
Yes.
you can rule out the toxicity in cardiac arrest. You can say any needle marks in his arms. What about his pupil? Like that. Clear?
Yes.
Okay. Yes, Muzammil?
Yeah, the same question, sir. We have to contact Toxbase because this is toxicity
Don't
as well.
contact until you find evidence. If they said, yes, there is marks, we found the needle marks, or they said, for example, we found the needle and the syringes in his pocket. Clear?
Yes, sir. Yes, sir.
Like that. Okay. So
Thank you.
in such a case, you will give um, naloxone, but naloxone will be above 30 degree temperature. Okay?
Yes, sir. Important.
Yes. Okay. Next one, Basamat.
Yes, doctor.
Yes. You will do same station again. Okay?
Okay.
You have 30 seconds and 6 minutes.
Good morning. I'm Dr. Basamat. I'm the ED registrar. May I know your name and grade, please? Can you take over? Are you ARS provider? Can you take over airway? I need another nurse to be responsible about saturation.
Patient arrived.
Any handover from ambulance crew?
The patient fell in bathroom.
Uh, um, how about is the patient conscious?
Unconscious.
Is the airway patent?
Patient is unconscious.
Look, listen, and feel any sign of life.
No signs of life.
Please activate adult resuscitation team. We have one patient in cardiac arrest. Start high quality CPR. 30 to 2, and insert 2 wide port IV cannula and connect the cardiac monitor and check the rhythm and take blood for biochemistry, toxicology, hematology, and the rhythm is showing PAA, and give 1 milligram. Can you check temperature with low reading thermometer?
26.
So the patient in PEA with hypothermia, so we'll continue high quality CPR. The most probably cause is hypothermia. We will hold all the medication until the medication until 30 degree. Continue 2 minutes pass. Still, can you check for the pulse?
No pulse.
Continue high quality CPR 30 to 2, and continue active and passive rewarming with IV fluid, warm oxygen IV fluid, and use the warmer, and insert urinary sterilization, check temperature again, and continue high quality CPR 30 to 2. How
Temperature
about
27.
still temperature is below 30, withhold all the medication and continue the active and passive rewarming and high quality CPR. And the patient now in shockable rhythm. Can you please give 200 joule synchronized shock biphasic and resume high quality CPR and check temperature. 2 minutes pass.
Temperature 27.
Any sign of life? No sign of life. Give 200 joule synchronized shock and 200 joule synchronized shock biphasic, and continue high quality CPR and continue reactive and passive rewarming and recheck the pulse and recheck the temperature. Sorry. 2 minutes pass. Any sign of life? Still patient is showing, monitor is showing shockable rhythm. Will give third shock and continue active and passive rewarming. Any temperature?
Temperature 27.
Continue high quality CPR, withhold all shock, and until temperature is 30. We've given 3 shocks now, and continue active and passive rewarming and high quality CPR. 2 minutes pass. What is the temperature now?
29.
Continue high quality CPR until 30. We cannot give any shock. Patient in shockable rhythm, and continue high quality CPR and active and passive rewarming. 2 minutes pass. Still, there is any sign of life? Is the pulse matching the monitor? Continue high and what is the temperature now?
Temperature 32 now.
We can give there is pulse or still patient in cardiac arrest? No pulse, so we'll give one DC shock, 200 joule biphasic, and we will consider the medication. We can give adrenaline every 6 to 10 minutes, and continue high quality CPR. And the most probably cause is still the hypothermia, and continue the active and passive rewarming. And we can consider amiodarone because we given now this is a fourth shock, 300 milligram IV bolus, and there is pulse.
Yes.
Congratulations, team. We achieved ROSC. We will reassess our patient. Is the airway pattern?
Patent.
Is patient conscious?
Yes.
Please apply high
Okay,
flow
thank you.
oxygen.
Thank you. Thank you. Okay, excellent, Basamat. Did you mention about passive and active warming in details? Like,
Yes,
okay,
yes,
like
yes.
IV fluids warm, humidified oxygen warm.
Fluids and I use warmer even.
Okay, so I will give you 9 out of 10. 9 out of 10. You're doing very well. You're fast. You're doing well. Your voice is clear, loud. You're showing leadership skills, resuscitation skills, organized, accuracy, almost to mention all the points. So you deserve a 10 out of 10. Okay. Uh, I said 9 because I wish you finish all the approach. I mean, after ROSC, if you do A, B, C, D, E, I mean, you finish airway points, breathing points, circulation points, disability points, exposure points, hand over this patient to blah, 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 ICU team and blah, blah, blah. So here in breathing, you will ask, what about blood gases? Because already you extracted in cardiac arrest, right?
Yes,
And in circulation, you will maintain, just verbalize. So in breathing, I'm talking about ROSC. In breathing, you will ask about blood gases and verbalize, maintain normocapnia and normoxemia. Easy? Then
yes,
in circulation, you will ask about the 4 points, then verbalize any blood results, do ECG, and maintain normotension. Clear now?
yes,
You should fix this approach in any ROSC. But what if you finish the station like that in the exam? Sometimes they give you 9 or 10. Easy?
yes,
Even you did not finish all the post-ROSC assessment? Yes. Because this station is long. This station is long. And all doctors will do the same practice. Clear now?
yes, doctor.
Okay. They are not expecting anyone to reach post-ROSC exposure or handover. Easy? Okay.
Yes.
You did well, thank you.
Okay.
Next one, I think Muzamman?
Yes, sir.
Yes. So the next station, this patient, your task, rapid sequence induction. For sure, conscious or unconscious?
Conscious.
Otherwise, why you will do rapid sequence induction, right?
Yes. Yes.
So your task, clear. So you will go inside the room, you will introduce yourself as usual, and I want you to emphasize on your task. You can say, I'm here to do
Rapid sequence induction.
induction. So you have 4 plans. Plan A, B, C, D, right? Plan
Yes.
A, how many attempts?
3 attempts.
Okay. If failed first plan, you will go for what?
Plan B.
No, wrong. If first attempt failed,
First
guys,
attempt.
you will go for?
Second attempt.
No, wrong.
Pre-oxygenate.
You
Critical
have
intubation.
back valve mask, then first attempt. Back valve mask, then second attempt. Back valve mask, then third attempt. Back valve mask, then plan A. Back valve mask, then plan D. Easy. Again, what is the first action? The first
Uh,
action, back valve mask.
back
Back
valve.
valve mask. Okay. In the room, in the exam, your position will be behind the head. All the station, clear?
The complete session behind the okay, right.
Because your task is rapid sequence induction.
Right, rapid sequence induction, right.
Okay. So, like for example, you call the anesthetist. When you call anesthetist, what is his position?
Yeah, behind the
Behind the head.
behind that.
When you call the anesthetist, he will not do anything for the patient, only airway. So you will find him behind the head, and he is not leaving his place. Okay.
Yes.
So you will do back valve mask for how long?
5 minutes.
5 minutes. Then after 5 minutes, so in 5 minutes, you will finish airway, breathing, circulation, disability, right?
Yes.
And so on. Then exposure, I need to hand over this patient to ICU team. Then go again for airway. The second A, you will intubate the patient. So first A, back valve mask. Second A, intubation. Third A, back valve mask. Fourth A, intubation. Like that. Easy?
So can I
So
stick to A, or we have to this one? This is only after complete. Then I will stick to A.
yes,
Second, A, third.
I'm talking for the real practice.
Okay, sir.
For the real practice and for the purpose of the exam. Clear?
Yes.
So now in the first A, you will do back valve mask. How long?
5 minutes.
Second A, you will do intubation. First attempt. Failed. What you will do? You will go for back valve mask again. Okay. So between every attempt, you have to go back for back valve mask. Easy?
Each
Yes.
time is 5 minutes.
Sorry?
Each time the return to back valve mask, it is 5 minutes.
Every back valve mask, 5 minutes.
Yes.
No problem if you cannot intubate the patient. Don't worry. You will not kill the patient. Just keep the back valve mask for 5 minutes and open the airway. Open the airway doesn't mean open the mouth. No. Sometimes the mouth is open, but the airway is closed. The patient is dying. So open the airway, it means head tilt, chin lift. Clear? And
Yes.
you should find the chest rise. If you find the chest rise, the airway is open. If no chest rise, the airway is closed. Even the mouth is open. Easy? Okay. So some people, unfortunately, even they are expert, they are killing the patient. Why? They are training junior doctors. They are saying, can take attempt. No problem. If you are helping junior doctor to intubate one patient, to train him, but at least pre-oxygenate the patient, number one. If he take attempt, try to pre-oxygenate again for 5 minutes. Whatever the junior doctor or you, don't intubate again without pre-oxygenation because the oxygen will fall. Okay. So pre-oxygenate, it means you will remove the nitrogen from the lungs. Normally, in all people, even us, you will find oxygen and the nitrogen. Oxygen 80%, nitrogen 20% in the lungs. So what we are doing, back valve mask, or non-rebreather mask, high flow oxygen, it means 15 liters. It means you will remove the nitrogen from the lung. So instead of saying oxygen 80%, nitrogen 20%, it means oxygen, how much?
100%.
100%. You are removing nitrogen. It's called denitrogenation. Denitrogenation, it means you are removing the nitrogen from the lungs. Why we are doing this? If the oxygen 100%, I'm not talking about the pulse oximeter, I'm talking about the oxygen saturation, PaO2, inside the blood. Okay, so if the saturation is 100, once you remove the back valve mask and you give the medication propofol, for example, then you are doing intubation. the saturation will fall from 100 to 92. It will take 4 minutes. It will take how long?
4 minutes.
4 minutes for the saturation to decrease from 100 to 92. Then it will take 1 minute to fall to 0.
Oh,
Can you imagine?
yes, sir.
Yes.
Didn't know this one.
Okay. This is the benefit of pre-oxygenation. 4 minutes more than enough to intubate at least 1 attempt, but not 5 attempts, right?
Yes.
So every pre-oxygenation will give you further 4 minutes. Easy?
Yes.
Every pre-oxygenation. Even you found the saturation is not reading, but the patient has oxygen in his blood. But don't depend on that. Anyway, so we will go for our point now. So plan A, 3 attempts. Plan B, 2 attempts, ideally 2 attempts, but you can consider plan B 1 attempt, no problem. Plan C, face mask ventilation, back valve mask, okay, one attempt. And plan D, surgical airway, 1 attempt, okay? So what is the first action?
Plan A. Pre-oxygenate. Back valve mask.
Back valve mask. Then tracheal intubation, easy? In plan A, they said face mask ventilation and tracheal intubation. They did not say tracheal intubation, right?
Okay. Yes, sir.
Then in plan B, they said what? Maintain oxygenation. Okay. So in what you will do with this patient, so you can verbalize my role, will do rapid sequence induction. Then in airway, you will ask about airway. For example, the patient airway is not patent, the patient has hoarseness of voice, the patient has a stridor, the patient has blah, blah, blah. You will verbalize, for example, the patient has anaphylaxis, okay? Because the scenarios I mentioned, the patient has blah, blah, blah after eating in a restaurant or anything like that. Okay. Then you are in airway. Don't finish airway until you prepare everything. So in airway, you will say, please prepare what?
All the airway equipment like 2
Yes,
bougies.
difficult airway trolley, number 1. Difficult airway trolley, okay? Then mention them by name. So you will say 2 or 3, 2 or 3 80 tubes, 2 or 3 laryngoscopes, different sizes, 2 or 3, okay? Oropharyngeal, nasopharyngeal, and blah, blah, blah. You will mention everything, okay?
Okay, sir.
You prepared the airway equipment. What about circulation equipment? I mean medications. So you should mention them. You have induction agents, muscle relaxant, analgesia. So you have triad for rapid sequence induction. Triad, it means anesthetic triad. It means induction agent, number 1. Number 2, muscle relaxant. Number 3,
Analgesic.
analgesia. The induction agent, you have 4 induction agents. You can use propofol, you can use ketamine, you can use etomidate, you can use thiopental or barbiturates. Okay? Did I
Okay.
mention midazolam?
No.
So, unfortunately, some doctors, they are not knowledgeable. They are intubating patients with midazolam. This mistake. Okay? Midazolam for sedation, but not for general anesthesia, not for rapid sequence induction. For conscious sedation, yes. So if you want the patient conscious and sedated in the meantime, it means a conscious sedation. So you will do, for example, synchronized DC shock, or you will do sutures, or you will do reduction of joint, okay? So you can use midazolam. You can use also in conscious sedation propofol, yes, but half dose, half, because conscious sedation. You can use ketamine, yes, but half dose. So what is the difference between conscious sedation and rapid sequence induction? Which one half dose, which one full dose?
Half dose is conscious sedation.
Yes, and general anesthesia or rapid sequence induction, we are using full dose. So,
Windows.
propofol here, 2 milligram per kilogram, but here, 1 milligram per kilogram. Easy?
Yes.
The ketamine in rapid sequence induction, 2 milligram per kilogram. In conscious sedation, 1 milligram per kilogram. Easy?
Yes, sir.
Yes.
Midazolam in only in conscious sedation, only in conscious sedation. Barbiturate or cybental in rapid sequence induction. Etomidate in rapid sequence induction. Easy? Okay.
Yes.
So we finished now the induction agents. Okay. Then we will go for muscle relaxant. You have two types. You can use depolarizing or non-depolarizing. If difficult for you, don't care about depolarizing or non-depolarizing. You can say succinylcholine or atracurium. Okay. Use succinylcholine or succinylcholine. You can say succinylcholine, the same succinylcholine. How much?
50%.
You are not sure? Mention 1 milligram per kilogram. Easy?
Okay, sir.
You
Yes.
said 0.3, no problem. You said 0.6, no problem. You said 1 milligram, no problem. Don't worry. Easy? Okay.
Yes.
We will go for fentanyl. 1 microgram per kilogram. Clear?
Yes.
So propofol 2, succinylcholine 1, and fentanyl 1 microgram. So 1 milligram for succinylcholine, 1 microgram for fentanyl. Okay, so you will prepare them. You will prepare airway equipment and circulation equipment in airway. Easy?
Yes, sir.
Okay. During assessment of airway.
Yes. Don't
Mm.
leave the airway until you prepare everything. Okay?
Okay.
Because your task is airway. Your task is rapid sequence induction. We finished this. Expose the chest to connect all monitors. The breathing, how many points in breathing?
8.
8 points. Done. Finished. Then circulation, how many points?
4.
4 points.
4 points. Okay. So regarding circulation, okay. So
The drugs we should mention in circulation or in airway only? Preparation of drugs.
preparation, you can prepare in airway so you will not forget. If I say prepare airway equipment before airway, circulation equipment in circulation, you will forget. So
Forget.
better to prepare all where
Airway.
airway. You will not forget
I will
that.
correct. I will correct any abnormality, Dr. Hani, like in circulation, the patient is shocked. I will correct.
Of course, of course. You can give high flow oxygen, even the oxygen is normal. You can give fluids, even the blood pressure is normal. Mandatory, mandatory. Any
So
sedation,
it is. Mm. Yes.
any sedation, you should give fluids. Okay?
Yes. So I will follow the general approach. A, B, C, D, E.
Yes,
Then I will return back to A for rapid sequence induction. Right?
you should finish A, B, C, D, E, and then I need to hand over this patient to ICU team. Then I will reassess the patient. I found the airway is still same problem of airway. Then I will intubate the patient. Clear? Okay.
Yes. Yes.
Let me to focus on the ABCD only. Okay. So now, good morning. I'm blah, blah, blah. May I know your name? And great, nice to meet you. Please prepare airway equipment and circulation equipment and handle airway and circulation. Thank you. My task is rapid sequence induction. Please prepare blah, 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 blah. So you will verbalize all. Easy? Okay.
Yes.
We finished now preparation of airway and circulation by name. Okay. Then I need to take handover from ambulance crew, the patient, blah, 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 blah. Okay. Is the patient conscious? Is the airway patent? The patient is conscious. Of course, they should say conscious because rapid sequence and that. Then is the airway patent? No, the patient has stridor hoarseness of voice and difficulty in breathing. So you can say this happened after eating seafood in restaurant, so it could be anaphylaxis. Call ICU team, including anesthetist, and please keep the patient on high flow oxygen, non-rebreather mask, 15 liters. Okay? Okay. Stay behind the head, then go for breathing. Expose the chest, connect all monitors, check the 8 points. Okay. Then go for circulation. Check the 4 points, normal. Okay. Insert two IV access, extract the blood for blah, 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 blah. And must cell tryptase because of anaphylaxis. Then give the patient fluids, 500 cc normal saline. Thank you. Here, you should give the medications of rapid sequence induction in circulation. Clear, Omar?
Yes.
So give propofol, blah, 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 blah. Give succinylcholine, blah, 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 blah. Give fentanyl, blah, 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 blah. Okay. Then you give them already. In the meantime, do pressure. Pressure where?
Okay.
Blood pressure.
Cricoid pressure. Clear?
Yes.
Yeah.
In the time you will give medication, remember to pressure. So remember pressure in circulation, pressure on the neck. Easy?
Yes.
Okay.
Okay. Why? Because the patient will lose his airway reflexes. He can get aspiration. So if you click on the cricoid membrane, so you are protecting the lungs. Okay.
Airway.
So go for disability, blah, 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 blah. Go for exposure, blah, blah, blah. I need to hand over this patient to ICU team. I will reassess the patient. 5 minutes passed. Okay. The first airway, we give already adrenaline. The first airway, we give already adrenaline in the first right side. Okay. Then in the second A, what about the patient? Still conscious? Yes, still conscious. Is the airway patent? No, still not patent. Hoarseness of voice strike. Okay, so you can give the second dose of adrenaline in the other side, in the left side. I will intubate. Is the anesthetist arrived? No. Okay, I will intubate the patient. So verbalize one time only, explain intubation, but every time you can intubate immediately. So you will intubate. I can see the vocal cords holding the laryngoscope left hand, see the vocal cords, insert the tube. Okay. Then you will connect to the tube connected to
Back and wall mask.
back valve mask. Give ventilation every
6.
6 seconds. Then inflate. Then inflate that tube. Then check the 4 points. What about bilateral chest rise? What about bilateral auscultation? What about SpO2? What about SdCO2? They are not reading. What does it mean?
Fail.
Problem intubation. Failed intubation.
Tube is out. Tube is out.
Yeah.
So what you will do?
Back
Deflate
valve
the
mask
tube.
ventilation.
Deflate the tube. Remove the tube. And attach what?
Back valve mask.
For how long?
5 minutes.
5 minutes.
5 minutes. Then now we finish the airway. We will go for
B. Breathing.
ask the
Again?
4 points again, or at least SpO2. Why I'm asking about SpO2? I want to see the back valve mask, the reoxygenation is improving the oxygen or not, right?
Yes.
So after back valve mask, what about SpO2? At least SpO2 with back valve mask, but with tube, mandatory to ask about the 4 points. Easy?
Yes. Yes.
Okay. With back valve mask, better also to ask about chest rise to check effect. Okay. So then circulation, what about blood pressure? Then just as then you can jump again to airway. 5 minutes passed. I will intubate the patient. Second attempt. Easy?
Yes.
مزمن.
Sir, in your previous classes, we didn't check for breathing, circulation, and this one. So previous classes we were stick with A only because it's a very big this case because three
Very
attacks.
long stage.
Yes, you can do like that. Or you want me to
Yes.
do?
Dr. Hani,
I
please,
can do.
this is better to do this case by yourself,
Okay.
please.
I will make 6 minutes and do for you.
Yes.
Good morning. I'm Dr. Blah blah blah. May I know your name and grade? Nice to meet you. Okay. I'm waiting for patient with something wrong, collapse in the restaurant after eating seafood. Okay. I need take handover from the ambulance crew. Blah 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 blah. Okay. Thank you. Is the patient conscious? The patient is conscious. Is the patient airway patent? No. Hoarseness of voice stridor. Okay, so the patient has hoarseness of voice stridor after eating in restaurant. It could be anaphylaxis. Please call anesthetist and ICU team. In the meantime, please prepare airway equipment and circulation for rapid sequence induction. This is my task now. So prepare for 3 80 tubes, 3 laryngoscopes, and oropharyngeal, nasopharyngeal, and bougie syringe. Okay, and SpO2, ATCO2, all equipment for difficult airway to Rowley. In the meantime, prepare for medication for rapid sequence induction. Prepare propofol 2 milligram per kilogram and succinylcholine 1 milligram per kilogram and prepare fentanyl 1 microgram per kilogram. Okay, thank you. In the meantime, pre-oxygenate for 5 minutes, back valve mask. Okay, thank you. Can you give adrenaline 1.5 milligram in the right side, anterolateral midpoint? Thank you. I will go for breathing. So expose the chest, connect all the monitor. What about SpO2, trachea, neck veins, RR, inspection, palpation, percussion, auscultation? Thank you. All are normal. Thank you. What about blood pressure? Normal. CRT, peripheral pulses, heart rate. Okay, so the ECG is normal, no problem. Okay, good. So what about insert 2 IV access, extract the blood for hematology by cerebral glycolysis screen, and give fluids and give the medications, please. Okay, in the meantime, I will click on cricoid pressure. Thank you. Then what about disability? HSS 15. What about pupils, echoreactive, and just any signs of lateralization? What about glucose, normal, exposure in temperature, any other abnormality? I need to hand over this patient to ICU team. Okay, thank you. I will reassess the patient 5 minutes past. What about the conscious level? Still conscious? What about airway still patent? No, same. So give the second dose adrenaline, same dose in the left side. Thank you. I will intubate the patient now. Please release the cricoid pressure 1 minute passed after the medication. Thank you. Left hand laryngoscope, right hand AT tube. I can see vocal cords. Insert the tube and connect to back valve mask. 1 ventilation every 6 seconds. What about bilateral chest rise, SpO2, ATCO2, and okay, they are not reading, so the tube is out. Deflate, remove, attach back valve mask. What about SpO2? Good. And blood pressure, good. GSS is still 15. Okay. 5 minutes passed. I will intubate second attempt. Pass. Attach it to back valve mask. What about bilateral chest rise, SpO2, ATCO2? Not reading, so it means the tube is out. Okay. Deflate and attach back valve mask for 5 minutes. What about SpO2? Normal. And what about chest rise? Okay. And blood pressure? Normal. What about GSS? Still conscious? Still GSS 15. Okay. So I will 5 minutes passed. Is the patient still conscious? Yes. What about airway still? Yes. So we can start adrenaline infusion, refractory anaphylaxis. Okay, 1 milligram over 1 hour over 100 normal saline. I will start the third attempt now. Okay, so attach to back valve mask is a tube. Then ask about SpO2, ATCO2, chest rise, bilateral auscultation, not reading, so the tube is out. Remove, deflate, remove. Attach back valve mask for 5 minutes, pre-oxygenation. What about SpO2, chest rise, normal. What about blood pressure, GCS, normal. Okay, so 5 minutes passed. Then, is the patient conscious? Yes. Is the airway patent? No, not patent. Anyway, the patient already on infusion and adrenaline. Okay, so 3 attempts failed. Uh, it means failed airway. I will go for plan B. So I will go for LMA and attach it to back valve mask. So what about SpO2, ATCO2, and bilateral chest rise? So not reading. Okay, so the LMA is out. I will remove, deflate, remove, and attach back valve mask, third attempt, final attempt. What about SpO2? Normal. And blood pressure, chest rise, GSS, normal. So I will keep the back valve mask and wait for anesthetist. Easy, guys?
Yes, sir.
Okay.
Sir, because we
Wait,
already
please.
treated
Wait,
the
please.
patient.
So now I'm in plan C. If I find the plan C, this is the final attempt for the back valve mask. Okay. If the patient has chest rise, it means succeed. If the patient has succeed plan C, what is the next action?
Wake
Wake
the
the
patient.
patient up.
Wake the patient. Okay. So what does it mean, wake the patient? You will do back valve mask, one ventilation every 6 seconds until the effect of rapid sequence induction finish.
Resolve.
Clear? What if the examiner said no, not reading? After back valve mask, the chest rise no effort and SpO2, ATCO2 not reading. So it means it failed. What is the next action?
Surgical cricothyroidectomy.
Surgical airway. They can ask you also how to do that. Yes. So I will give you idea how to do that, guys. So you will do 2 surgical wounds. How many surgical wounds?
Two
Two.
2 surgical wounds. You can remember VH. V vertical, H horizontal. Which one is first?
vertical.
Vertical.
Remember VH. Vertical, then horizontal. So you will, if this is emergency, don't care um, about anesthesia because emergency. Okay, so you will do incision vertical, then horizontal. You will use retractor and you will use the bougie. Once you have already the next wound, it means you can see the trachea, you can insert the bougie, you can feel the click with the trachea, and you can thread tube on the bougie. Okay, can you imagine, guys? So the bougie inside. So you have a scalpel in the beginning, the start. I will explain again. You have a scalpel. Okay, so you already cleaned quickly. Then wound vertical or horizontal?
Vertical.
Vertical. In which area? Cricothyroid membrane. It means between thyroid and the cricoid cartilage. Easy?
Yes, sir.
Feel the thyroid cartilage, cricoid cartilage, so it will be between thyrocricoid membrane. Okay. Cricothyroid membrane. So vertical, vertical, okay, and then retractor, and then horizontal incision wound, and then you can pass the bougie.
Brain.
You can feel the click in the trachea. Then you can thread tube, 80 tube. Cuffed or uncuffed?
Uncuffed.
Cuffed. Cuffed.
The size is 6, okay? Then after inserting the tube, you will attach it to
Back valve.
back
Valve
valve
mask.
mask. Same, one ventilation every 6 seconds. Check the 4 points. What about chest rise? What about auscultation? What about SpO2? What about TCO2? Of course, he will say all normal. Otherwise, you will kill the.
Yes.
Okay. So I think the station, even if long and you are controlling everything, it will be easy for you. And in breathing, if you are asking about the 8 points, you can ask about all together. Clear, Muzammil? For example,
Yes.
you can say, what about SpO2, RR, trachea, neck veins, chest inspection, palpation, percussion, auscultation. You can ask about the 8 points one time, no problem, don't worry. Clear? To save time. In circulation, you can ask about the 4 points one time? Yes. What about blood pressure, CRT, heart rate, peripheral pulses? In disability, you can ask about the 4 points one time? Yes. What about GCS, pupils, like that? You can ask about everything together. Okay. Are you happy to do this station?
Yes, sir.
Okay.
Good morning. I'm Dr. Muzamil, the ED registrar. May I know your name and grades, please? Thank you. We are receiving one patient who has collapsed in the restaurant. So I'm here to prepare to do rapid sugar induction. So prepare all airway equipments and circulatory equipments. Please prepare 2 bougies, 3 laryngoscopes of different size, and the 3 ETT tubes, oral pharyngeal airway, naropharyngeal airway, and syringe and tie and HME filters and all. And for the medication, you can prepare propofol 2 mg per kg body weight, ketamine, succinil 1 mg per kg body weight, and fentanyl 1 microgram per kg body weight. Okay, has the patient arrived?
Yes.
Any handover from the ambulance crew?
Yes, the patient was eating seafood in a restaurant. Suddenly, he has hoarseness of voice, stridor, and difficulty breathing.
Okay. Anything given in the ambulance? Any medications?
We give him IM adrenaline 1 dose.
Okay, thank you. Is the patient conscious?
The patient is conscious.
Okay. Is the airway patent?
Hoarseness of voice, stridor.
Oh, so this patient has hoarseness of voice after eating seafood in the restaurant. So it could be anaphylaxis. Already adrenaline has been given. So call ICU team and call the anesthetist. We may require early intubation and prepare all the things which I have told you earlier. Let me assess his breathing. Expose the chest, connect to all the monitors and defib pads. What is SpO2, respiratory rate, trachea and neck veins?
Normal.
Okay, inspection of the chest, palpation of the chest, percussion of the chest, auscultation of heart and lungs.
Normal.
Okay. Coming to circulation, what is blood pressure, CRT, peripheral pulses, and heart rate?
Normal.
So put 2 IV bore cannulas, extract blood for hematology, biochemistry, blood gases, blood culture, and toxicology screening, and give IV fluids, normal saline 500 ml, and give medications which I told: propofol, fentanyl, and succinylcholine as per the dose I've told you earlier, and apply cricoid pressure before giving the medications. Coming to the disability, what is the GCS?
15.
Pupils and lateralizing signs?
Normal.
Blood sugars?
Normal.
Expose the body and check any abnormality. What is the temperature?
Normal.
Has the ICU team arrived? Any anesthetists arrived? I want to hand over the patient to them. No one arrived. Let me reassess. How about the airway?
The airway is still not patent.
Okay, 5 minutes passed. I think airway is still not patent. We will give second dose of adrenaline, 0.5 mg in the anterior lateral aspect of the left thigh. And I will do intubation. 1 minute passed after giving medications. Please release cricoid pressure. I will intubate the patient. I can see the vocal cords laryngoscope in my left hand with the AT tube. I intubated the patient. Please inflate the cuff and attach to bag and ball mask. Please check any chest rise, any auscultation. What about ETO2, ETCO2, SpO2?
Not reading.
Oh, failed. So deflate the cup and remove the AT tube and attach back ball mask and pre-oxygenate for 5 minutes. What is the SpO2?
Normal.
Bilateral rise?
Normal.
Blood pressure?
Normal.
Okay. 5 minutes passed. Then I will try for second attempt. I have intubated the patient with the ET tube and connect to bag and ball mask. How about the chest rise, bilateral auscultation, and ETCO2, SpO2?
Not reading.
Not reading. Failed attempt. Deflate the cuff and remove the tube and attach back ball mask for 5 minutes. Complete pre-oxygenate. What is the SpO2?
Normal.
Bilateral chest rise?
Normal.
Okay. Blood pressure?
Normal.
5 minutes passed. I will do a third attempt. I have intubated the patient again, attached to bag and valve mask, inflate the cuff. What about the bilateral chest size, auscultation, ETCO2, SpO2?
Not reading.
Oh, we have guys immediately remove the ET tube, deflate the cuff, and remove the ET tube and attach bag and valve. It is failed plan A. We have to go for plan B. Pre-oxygenate for 5 minutes. What is the SpO2 bilateral chest rise?
Normal.
Okay. What about blood pressure?
Normal.
Okay. Let me go for LMA, supraglottic airway, laryngeal mass airway. So I have put the LMA and attached to bag and valve mask. What about the chest rise, bilateral auscultation, and SpO2, ETCO2?
Not reading.
Not reading. Oh my God. So we will. This is the failed plan B. We will immediately remove LMA, attach the bag and valve mask, and pre-oxygenate for 5 minutes. What about ETC? What about bilateral chest rise, SpO2?
Not reading.
Not reading. Okay. Then this is failed plan C also, because we have pre-oxygenate. Then we will go for cricoid surgical airway, and please keep. I'll give one sterile the area, give vertical incision at the cricoid membrane between thyroid cartilage and cricoid cartilage, retract it, and then give horizontal incision on the cricothyroid membrane. Okay, and then put the bougie. I can hear the click. Then overall the tracheostomy tube over it with size 6, and attach bag and valve mask. And let me check now bilateral chest size, ETCO2, SpO2, and
Reading now.
sorry.
Reading.
Reading. Good, guys. Successful surgical airway. Please let me fix the tube.
The
Fix the
anesthetist arrived.
as attached ventilator. Let me reassess
Okay,
the.
thank you. Okay.
Yes.
So you did very well. You can manage within 60 minutes, and in the exam you will find the further 2 minutes, right?
Yes, sir.
Yes, it's easy.
So my right?
Sorry?
My approach is right, sir.
Yes, you did very well. Okay. You ask about SpO2 after back valve mask. Every back valve mask, whatever with intubation or without intubation, whatever with LMA or without LMA, you should ask about the 4 points, ideally. Clear?
Okay, sir.
And you should ask about blood pressure GSS also. Yes, this is ideal. If you did not ask about blood pressure and the GSS, it's not a big issue. Don't worry. Okay.
That was a doubt, sir. GCS, because we already sedated them, already paralyzed. So GCS will be like patient will be in sedated mode. That's what I was.
Yes. So here, regarding anaphylaxis, maybe they can give you different diagnosis. Okay. So
Yes.
if they give you diagnosis of anaphylaxis, it means every airway you should take action. So you will give the first dose of adrenaline, then in the next A, you will give the second dose of adrenaline. In the third airway,
Yeah.
you can start infusion. You can start infusion. Okay.
Yeah, I missed that one.
Okay. So, yes, you are correct. Regarding sedation, the first A, the patient is GCS 15. The second A, the GCS will be sedated. Okay. You can verbalize to yourself. You can answer yourself. No need to ask the examiner. Clear?
Yes, sir.
So in the second day, you can say, what about GCS? The patient is sedated already. Is the airway patent? No, still not patent. So you can answer yourself for the GCS, and you can wait for the response regarding the airway patent or not. Okay?
Okay, sir.
If he did not answer you, no problem. You can intubate because your task is rapid sequence induction. Okay?
Sure, sir.
In different station, if your task not rapid sequence induction and the examiner ignored you, you can ignore the airway. You can go for breathing. I wish you get my point.
Yes, sir.
Because your task is rapid sequence induction, it means you should intubate.
Right, sir.
Okay. I will give you 9 out of 10. You did very well. Okay.
Thank you.
Dr.
Sir,
Hani,
one last
question, please.
Yes,
Contraindication.
please.
Sir, if succinylcholine is contraindicated, like hyperkalemia, what other drug apart from succinylcholine we can give?
Atracurium.
Sir, dose please.
I think 0.6, something like that. Is
Okay,
it
sir.
possible?
Okay.
Yes, Amar?
So we have two in plan A, two attempts of intubation. Right?
In plan A, 3 attempts.
Three. I
3
think you said
attempts
two.
and 1 expert.
Yes, 3 attempts in plan A. Then plan B, laryngeal supraglottic device, right?
Yes.
Then plan C,
Back valve mask.
bag mask
Yes.
until the patient wake up.
So in plan A, back valve mask, then intubation. Back valve mask, intubation. Back valve mask, intubation. If expert, back valve mask, intubation. If failed, plan B. Plan B, it will be back valve mask and LMA. Clear?
Yes,
In plan C, back valve mask only. No ETT,
until
no
until
LMA.
okay, until the patient wake up.
If succeeds,
If succeed, yes,
it means, so how to know plan A succeed or not? Chest rise and blah 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 blah. Plan B, how to know it's succeed or not? So chest rise, SpO2, EtSO2, and so on. Plan C, how to know? Same. Chest rise, EtSO2, SpO2, bilateral auscultation, like that. Clear?
yes,
If you find the 4 point good, so you will go for wake the patient. You will continue
okay,
plan C until the anesthetist will come, until the patient will be awake, and the anesthetist will intubate. Clear? If plan C failed, the examiner said no chest rise, no auscultation, no air entry, and also SpO2 is decreasing or zero or not reading. So it means it failed. You can go for plan D. Easy?
yes. Okay, thank you.
Welcome. Okay. We will go for the next one, I think. Who did not practice, guys? Or who is happy to practice the next one and the last station? It will be the same, but in
I will do
cardiac
it.
arrest. Who is happy to do this one?
Obey.
I will practice, sir.
Okay.
Huh?
I will practice, sir.
Okay, Muzammil. So
Yes.
this patient has cardiac arrest. In previous station, rapid sequence induction every 5 minutes, but in cardiac arrest every
2 minutes.
2 minutes, because every cycle 2 minutes. Okay, this is easier and shorter because no rapid sequence induction. Clear? No
Yes.
medication. The patient already unconscious. The patient already in cardiac arrest. No need for sedation. Clear, guys?
Yes.
So you will do the same. You will be where? Behind the head. Okay?
Yes, sir.
You will be behind the head. Okay? So here regarding sometimes they will give you ECG. I mean rhythm. Okay? So for example, they can give you BA or I mean shockable or non-shockable. So what is your task?
Intubate the patient.
Intubate or resuscitate? Intubate.
Intubate.
So you can do intubation only. Better to do intubation and resuscitation in the exam if you are not sure. Clear?
Okay, sir.
So for example, I will do quickly just to show you. Good morning, Amber. May I know your name? Please prepare airway equipment. My task is to
Intubate the patient.
intubate the patient. Done. You will be where? Behind the head. Okay, please. I will confirm. Stop for a while. I will confirm. Is the patient conscious? The patient is unconscious. Any signs of life? No signs of life. So the patient in cardiac arrest, call adult or activate adult cardiac arrest to call and start high quality CPR 30 to 2. Easy?
Yes, sir.
Yes.
Okay. Attach monitors. Maybe the examiner will show you the monitor. When you say attach a monitor, maybe this one, maybe this one, maybe he will ignore you. If the examiner ignored the rhythm, he's forcing you to focus on the airway. Easy?
Yes, sir.
Yes.
And it will be good. If he show you the rhythm, it means you should intubate the patient and give adrenaline if non-shockable, or give shock if shockable. Easy?
Yes, sir.
Yes.
Okay. So anyway, the patient in cardiac arrest and your team are doing now CPR. For how long?
2 minutes.
2
2
minutes.
minutes.
2 minutes. Excellent. You will check the ventilation. You, doctor, your task same as anesthetist now. So you will do 2 ventilation every
30 seconds.
30 compressions.
30
30
compression.
compression.
Excellent. So within 30 compression, you have time to prepare yourself, right?
Yes.
Yes.
The nurse is doing chest compression. 1, 2, 3, 4, 5. So you just put the back valve mask and verbalize head tilt, chin lift. Easy.
Okay, sir.
Yes.
Put oropharyngeal, nasopharyngeal, clear the airway. Clear now?
Okay, sir.
Yes.
So within 30 compression, you have to verbalize these points. Again, please continue high quality CPR or start high quality CPR. If you go inside the room and you found them, they are doing high quality CPR, you can tell them, please stop for a while. I want to confirm cardiac arrest. Any signs of life? They said no signs of life. Okay. So please continue high quality CPR and call adult resuscitation team or activate cardiac arrest call. Easy this point?
Yes, sir.
Okay. So I will go for the point now of airway. My task is airway. I mean, I should clear the airway. I should open the airway, clear the airway, maintain the airway open. It means oro and naso. Easy?
Yes.
Okay. So again, you are doing high quality CPR. My task is to intubate the patient. I will prepare difficult airway trolley, 3 80 tubes, 3 laryngoscopes, different sizes, 3 oropharyngeal, 3 nasopharyngeal, and suction for fine rigid and magle forceps. Clear? Okay.
Yes.
Then head tilt, chin lift, open the airway, oropharyngeal airway, nasopharyngeal airway, clear the airway. I will attach a back valve mask. Every 30 compression, I will give 2. 1, 2. Easy? You are
Yes.
showing the examiner, you are giving it 2 now. Then you are asking the nurse, continue 30 again. Easy? Like that.
Yes.
Okay. Then if they show you the monitor, you can say, I can see non-shockable rhythm. Please give the patient insert 2 IV access, extract blood for blah 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 blah. So you finished the airway already. So we will focus on C now, circulation. Okay. So insert 2 IV access, extract the blood for blah 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 blah, and give the patient fluids and give the patient what? Adrenaline. I will consider for H40s. If you find a clear cause in the scenario, mention. For example, in this scenario, did they mention any clear cause?
No.
No. Did they mention chest pain? Did they mention, for example, eating in a restaurant? Did they mention CKD? Did they mention any hypothermia? No. So just to verbalize, I will consider what?
For H40s.
For
For
H40.
H40s.
More than enough. Okay. Then you can go for your airway again. 2 minutes passed. Please stop for a while. Less than 10 seconds. I will intubate the patient. Easy.
Okay.
Left hand, laryngoscope. Right hand, ET tube. In vocal cords. Attached to back valve mask. And I will check bilateral chest rise and auscultation. The examiner said not reading. What you will say?
Very frustrating.
Deflate. So the tube is
Tube.
out. Deflate, remove the tube, and attach what?
Back valve mask.
Back valve mask. And resume high quality CPR
Yes.
for how long?
2
2
minutes.
minutes.
For 2 minutes. Easy?
Yes.
And repeat the same every 2 minutes. Okay. So 2 minutes pre-oxygenation, then intubation. 2 minutes pre-oxygenation, then intubation. 2 minutes pre-oxygenation, then intubation. So 3 attempts failed. It means they failed the plan A. We will go for plan
B.
B.
B. LMA, same, attached to back valve mask. You will give ventilation and then you will check bilateral chest rise auscultation. Easy, Muzammil?
Yes, sir.
The same idea. Okay, so you will check the rhythm and you will intubate every 2 minutes.
Yes.
If you are happy to start, you can start.
Good morning. I'm Dr. Muzammil, the ED registrar. Hi guys. Can you just stop for a while? CPR is going. Let me check the pulse is there. And check.
No signs of life, doctor.
No signs of life. Please continue CPR. I'm here to do intubation. Please continue high quality CPR. And I'll be near the head end of the patient and put 2 IV bore cannulas, establish hematology, diagnostic, blood culture, and toxicology screening, and start IV fluids and prepare airway equipments, 2 gauges, 3 laryngoscope different sizes and 3 ET tubes, oropharyngeal airway, naropharyngeal airway, and suction and tie and syringes and HME filter. Okay, continue the compressions. I will give 2 breaths after 30 compressions, and I will intubate the patient after 2 minutes. 2 minutes pass. Stop, switch, analyze the rhythm. Okay, this is non-shockable rhythm, and I will intubate less than 10 seconds. No pulse present. Intubate the patient with a tube. Okay, connect to bag and valve mask. Inflate the tube. Any bilateral chest rise? Any auscultation?
No.
No, this failed. Deflate the tube and remove the tube, and please resume high quality CPR and give adrenaline 1 mg and continue high quality CPR 30 compressions, and I will give 2 breaths after 30 compressions, and I will assess 4H and 4Ts regarding this. 2 minutes pass. I will intubate the patient again. Stop, switch, analyze the rhythm. And still PK, non-shockable rhythm. And I will intubate, attach to bag and valve mask, inflate the tube. Is the bilateral chest rise? What about the auscultation? It is CO2, SpO2?
Not reading.
Not reading. Please deflate the tube, remove the tube. Please continue high quality CPR for another 2 minutes, and we will give adrenaline after 4 minutes, second dose, because the rhythm is pulsed electrical activity. So continue CPR for another 2 minutes, and then 2 minutes pass. Stop, switch, analyze the rhythm. Rhythm is ventricular fibrillation. Please, sister, charge the defibrillator. Till then, I will intubate the patient. Will give shock first. Unsynchronized DC shock, 200 joules. Shock given, and I will intubate the patient. Tube in place, attached to bag and valve mask, bilateral chest rise, auscultation, and it is SpO2.
Not reading.
Not reading. Please deflate the tube, remove the tube, continue high quality CPR. I will reassess the rhythm after 2 minutes. Continue high quality CPR, 30 compressions followed by 2 breaths. I'll give 2 breaths. 2 attempts failed. I will do 3rd attempt. Any 4H, 4Ts, what do you guys think? Let me intubate the patient. Stop, switch, analyze the rhythm. 2 minutes pass. What is the rhythm? Rhythm is still VEF, so I'll give unsynchronized DC shock, 200 joules. Shock given, everyone clear, shock given, and I will intubate the patient. Again, T tube, bag and valve mask attached, inflate the tube, bilateral chest rise, it is CO2, SpO2, and this one, auscultation.
Not reading.
Fail plan A, remove the tube, deflate the tube and remove the tube, continue high quality CPR. I will again assess 4H and 4Ts, continue high quality CPR, 30s to 2 compressions followed by 2 breaths. This is a failed plan A. I will I will do plan B, LMA after 2 minutes. 2 minutes pass, stop, switch, analyze the rhythm. What is the rhythm? Still in BF, give unsynchronized DC shock, 200 joules. Everyone clear, all clear, shock delivered. I'll put LMA attached to bag and ball mask and check for bilateral chest rise, ET should SPO2 and auscultation. Still not reading. Continue high quality CPR and give. We have given 3 shocks. We will give amiodarone 300 mg IV and continue high quality CPR 30 compression followed by 2 breaths. I will reassess after 2 minutes. Has the anesthetist arrived? Did we call anesthetist for the intubation? Okay, let me assist after 2 minutes pass. Stop, switch, analyze the rhythm. What is the rhythm? Same rhythm, ventricular fibrillation. So we'll give another shock, unsynchronized DC shock 200 joules. This is the 4th shock. Okay, and is with the ET with the background mass any chest rise bilateral auscultation ET pseudo is there?
No.
No, not there. Okay. But we will please prepare for surgical. Continue high quality CPR and prepare for surgical airway. We may have to do surgical airway now at the 2 minutes. After the 2 minutes, in less than 10 seconds, we have to do surgical airway. Continue high quality CPR. Then ongoing CPR 2 minutes pass. Then I will not 2 minutes. Continue CPR. I'll put a vertical incision at the cricothyroid membrane between the cricoid cartilage and thyroid cartilage and retract and do horizontal incision. And then I'll push the bougie. Kicking sound is there. Then overriding the tracheostomy tube size 6 and connect to bag and ball mask, and then I will reassess after 2 minutes. Okay, 2 minutes pass. Stop, switch, analyze the rhythm. What is the rhythm? Okay, rhythm is there. Pulse is there.
Yes.
Bag and ball mask, bilateral chest rise, ET CO2
Yes.
SPO2 consultation. Good guys. We achieved the ROSC and airway is in place. Please call the anesthetist, call the institute. I want to hand over the patient and
Okay,
fix the.
thank you. Thank you, Muzammil. Excellent. Okay, well done. 10 marks. Okay,
Thank you, sir.
well done. You are doing good. So, again, maybe they will not show you any rhythm. Maybe they will show any of the shockable or non-shockable. So, again, you can deal with the station. If they show you rhythm, manage as Muzammil did. Here you have plan A, 3 attempts, plan B, 1 or 2 attempts, plan C, 1 attempt, final back valve mask, and the plan D, surgical airway. So whatever the patient alive or in cardiac arrest is the same idea, but in a live patient, you will do rapid sequence induction, means you will give sedation, and it will be every 5 minutes. But in cardiac arrest, it will be every 2 minutes. I wish it's clear, guys.
Yes, sir.
Yes, thank you, guys. Inshallah, next decision when?
Day after tomorrow, Wednesday.
Monday.
Monday.
Monday. It will be ABLS and the newborn resuscitation. Okay?
Okay.
Please prepare well, listen to previous recordings, and be ready. The timing will be same, 12 p.m. UK time. Thank you,
Inshallah.
guys. Thank you. Bye-bye.
Bye.
Thank you.
Bye-bye.
Thank you.